Okay.
Now, the idea is to share the video and the slides as a PowerPoint PDF once the presentation's been given. So that will be available. Either you can request it to be emailed you directly, or it'll go up onto the Facebook group.
Well, I don't know if it's stuck.
I think Natasha might need to mute herself. Yep. All right. Okay, it's recording.
Yep. All right. Well, I think we can
get going.
We can most certainly, I think, start. So thank you again, and Kate, please hit on to the next slide. One of the things that we've noticed in dealing with schools, in particular, my background is having a FND teenager who's just finished school this past year, was that the ability to collaborate with different parties became the key factor on whether or not a particular part of being able to transition or being able to be successful at getting somewhere. The main part of it was to be able to collaborate. If we weren't able to collaborate, we most certainly weren't able to be able to get what we needed, and my daughter wasn't necessarily able to get what she needed to be able to get through. Now, my daughter did get through university, did get through to university, and did get through year 12. But at several points along the way, we most certainly thought that it was touch and go, that she might not make it, and that either she wouldn't make it, as in she wouldn't make it as in alive, and other times we didn't think she'd make it through year 12 and even be able to sit exams and sit assignments due to FND symptoms. So that's from my perspective, being the parent of and having just gone through that situation. So that's the type of information I'm bringing to the presentation. Kate is, I'm sure she'll be able to introduce herself. She's coming from a clinical background and a person who has FND, and we have Pat here as well, who's also got some information in regards to inclusion. So
yeah, Jeff, I work.
Sorry, Pat, sorry.
Yeah, so I was going to say I work as a learning and support teacher within the New South Wales system. So it might be a little bit different to what happens in Queensland. Yep. But yeah, I have some insider experience from, I guess, the school kind of perspective.
Yeah. And that's excellent, because mine is almost exclusively Queensland based. So in that sense, I most certainly am only going to be able to speak to Queensland's particulars, but I most certainly will try and speak to some of the broader implications across some of the other schools I do know of in other states. So.
Okay, so some of the things that we'll be covering today is I'll be looking, as Jeff mentioned, from a bit of a clinical aspect. I think we have some people who are fairly new to FND, so just going through a little bit around what is FND, what does the diagnosis mean, what are the risk factors, what is the impact of the diagnosis, and some of the symptoms that we see. And so in terms of what the school might see, what might be obvious to schools and what might also not be obvious to schools. And then how do we support inclusion within schools, recognising that education is really important for a child's well-being. So supporting the child with FND to be able to attend school is a really important, from an OT perspective, it's a very important occupation for the child. So it's important that children are able to attend school, get that sort of developmental side of things happening while managing their FND. But Jeff, did you want to talk a bit about your side?
Yeah, in terms of my experience with my teenager, we most certainly had times when we were looking at what might be different if she had to then move to another state. We did also look at how she was able to be accommodated in the school environment, and what things had to happen from our end, and the things that we encouraged the school to do, as well as things we also encouraged the teachers and the students around her to do, as well as some of the things that came up as key turning points in her condition and in her time at school. Some of those things were things like hiding, transitioning to different things, exams, friends, there were social challenges, isolation. And then there was always the question of what if school wasn't going to happen for her? And then what would happen if school did happen and then we got to the end, what was next? So we did cover all of those. And one of the things that did make it a little bit easier for our situation was that my daughter did have a life-threatening heart condition when she was younger. So a lot of the techniques that we used during that time, during primary school and early high school, we were able to repeat and were often successful with those same techniques.
All right, so by way of introduction, I think Jeff's already covered this off. I'm the president and founder of FND Australia Support Services. The organisation started really because of my lived experience. And I'm also an occupational therapist, so I see a number of people with FND through the organisation, and I do support children and their families and schools with kids with FND. Jeff?
Yeah, and I'm a dad of two girls, both with special needs. My teenager having FND and a previous heart condition, supraventricular tachycardia, or SVT for short, which she had from age 5 through to surgery just before she started high school. And I have another special needs child who is 11, and I'm currently between jobs at the moment. So I'm an IT person, so from that, it was definitely a new experience for me for having to deal with a whole lot of medical challenges that I wasn't necessarily ready for when my daughter all of a sudden had her first episodes for heart condition. So that's my start. And Pat, do you mind giving yourself a little bit of a brief?
No problem. So my name is Patrick Hobbs, and I've come into the FND community as a trainee counsellor. So I'm supporting Kate's counselling outreach program for people living with FND. So I'm learning a lot about how people are kind of experiencing this condition in lots of different varied and very individual ways and how they're coping. And I'm blown away, actually, by the kind of resilience that I'm seeing out there with people. So I'm keen to learn about people's experiences with schools as well. I have some experience as a learning and support teacher, sort of working with the learning and support team in a school in Campbelltown in New South Wales so sort of on the outer fringes of Sydney. But we've never had anyone with a FND. But there are some kind of protocols in place within the department for dealing with students with a disability. So I'm interested to see what people's feedback is if anyone's had that experience of trying to negotiate with the school. And I thought I would talk specifically about the HSC special provisions because I made some inquiries this week with the department around that because they have to have a special dispensation for people with conditions like chronic fatigue and FND. Yeah. So I'll tack that on to the end of the presentation of Kath and Jeff.
Yeah, and I can speak from the Queensland point of view, having had filled in all those forms for my daughter.
Yes.
So yes, it's a form nightmare when it comes to that one, but it is possible.
Alrighty, so I'm just going to give a bit of introduction to FND because I'm aware that there were some people signing up who are sort of new to FND, and education, like understanding the diagnosis, is really important. And for a lot of people who come down with FND, they're not told much about it. Some people may be given the label, some people may not even be told the diagnosis. They might find the diagnosis in their medical notes. And a lot of people come to us and really quite confused. Their families are confused. They don't understand what they're dealing with. They're given no information and they're not given appropriate referral processes. So a brief summary of FND is it's a complex and poorly understood neurological condition. The symptoms are really significant. So the symptoms can include like limb weakness, limb paralysis, full body paralysis, gait disorder. So people may be unable to walk. Seizures are very common. A lot of people live with chronic pain, chronic fatigue. Some people might have tremors and abnormal movements, jerks. Some people also have speech problems. People can lose their voice. People can have problems swallowing, which can get life-threatening when people can't eat and drink. And there may also be continence issues as well. So really disabling and distressing symptoms that people are living with. And one of the big issues that people, I think someone's on sound, we might need to mute someone that's making a sound. One of the challenges of FND is that the routine medical testing that's done in hospitals, that's done in a doctor's surgery, often comes back normal. So people are sort of sent away, and some people are, being labelled as hypochondriacs or worse, accused of faking. So the symptoms are very serious. So the routine medical testing is often normal. But the FND can be diagnosed through positive signs. So a neurologist, there's certain signs that they can do, various tests, which can give an indication that it could be FND. There is no quick fix for FND. So generally, especially for people who are new to the diagnosis, a multidisciplinary rehabilitation team is often applied. So a person might see a physio, they might see a psychologist, they might see a neurologist, a psychiatrist, an occupational therapist, a speech therapist, and they really try to help the person with their movements and get their movements back to sort of get that automatic movement happening again. And that can be helpful for first episode conditions, and also when we're dealing with children. So children have better outcomes, their brain's more neuroplastic. So it's really important that children get the opportunity to have that rehabilitation in order to prevent sort of long-term disability. So outcomes vary in terms of prognosis. We see some people who become really, really disabled and symptomatic, for a long term. But then we also see some people who might just have a single episode and then they might improve. So some people might have it for a few months and improve. Some people might have it for a couple of years and improve. And then we have some people who get progressively worse over time. And there's various reasons for that. But generally, the earlier that the condition is diagnosed, the earlier the person gets access to treatment. The person needs to have good experiences, so having good treatment team around them, good supports around them who are really listening to the person. All of those things can be really helpful. And this is a positive experience of diagnosis and treatment. So people who feel positive about the treatment and feel supported, and people who have fewer comorbidities. So if a person has a lot of other physical health problems or trauma or other mental health problems, or are living in, a very difficult situation with a lot of stressors, they're all things that can impact the well-being. But generally, we tend to find that children have better outcomes than adults, not exclusively, but in general, they do, and that is because the brain is more neuroplastic. So a lot of people will spend a lot of time trying to work out what is the cause of my FND. And for some people, there may be an identifiable trigger, something happened and then the condition developed, or it could have happened after a surgery, after an injection, after a medication side effect. So for some people, there may be an identifiable cause. But for a lot of people, there won't be. Some people say, look, I was always healthy. This just came out of the blue. Sometimes people may not recognise things that might have been impacting on them, but we often find that people will develop FND either after pain, after an accident, a car accident, an injury, surgery, or just if there's a lot of overwhelming stressors, either physically, as in health-wise, or mentally. But generally we might see that the person has multiple risk factors. So it could sort of be, the straw that broke the camel's back sort of thing, and they developed FND. But there's definitely, for some people, a trigger or a cause will never be found, and they may have had absolutely no underlying health conditions previously. So a bit of a mixed bag. So just like, there's many ways that you can break a bone. There's many reasons why people come down with FND, but what we need to start addressing is, instead of trying to look at all the reasons why the person might have come down, because there may not be anything that we can do about that, we need to deal with the problem. And the person has a dysregulated nervous system with, motor, sensory and other neurological problems. So we need to address the symptoms and help the person recover as best they can. So with FND, I mentioned that often the routine medical testing comes back normal. So traditionally, a doctor might do some blood tests. They might send the person for an MRI, a structural MRI of the brain, possibly the spinal cord. They might come back and go, your CT normal, your MRI is normal, your blood tests are normal. But what they're looking at when they do those imaging is they're looking at the structure. They're looking at the structure of the brain and the structure of the spinal cord. So frequently with FND, that will come back normal unless the person has another neurological condition that impacts the brain and spinal cord. But what we have with FND is that it's a problem in the functioning of the nervous system. So a scan that looks at the structure of the nervous system is not going to be detecting what's happening in the function of the nervous system. So functional MRIs look at the brain functioning under certain conditions, and this is done in the research laboratory. So in the research setting, they're finding that people with FND have significant changes in the way the nervous system functions, in the way their brain functions, and that is different to people who are healthy controls, and it's also different to people who might be faking a certain symptom. And what we also find is that people who have motor symptoms will have low activation of the motor cortex. So this low activation of the motor cortex reflects their symptoms. And likewise, people who have vision disturbances, who might be blind through FND, will have hypoactivity of the region that controls vision. So the new research is starting to identify what is going wrong in the brain of people with FND, but this has not yet translated into routine medical testing. So a number of analogies can be used to describe the condition. So one that's frequently used, that's reported in the scientific literature, is with FND, if you think about the brain as a computer, the brain and the nervous system is like a computer. So in FND, the hardware is okay in most cases, unless there's another underlying condition. But what's going wrong in FND is that there's a software malfunction. And, I'm sure you've all had times where your computer looks structurally fine, there's no broken screen, there's no broken keyboard, but for some reason it's not working. There's a virus malfunction and your computer software has just gone. That is an analogy like FND. It's just not functioning the way it should, even though the hardware is intact. Or another analogy that Jeff put together, it's this fantastic diagram, is that, we can have a phone. We can have a mobile phone that's fine. It's not broken. It's all good. But yet when we're trying to talk on the phone, for some reason there's interference and we're getting, missing conversations. The sound is not there. We can't make sense of the conversation because the signals are interrupted. So again, that's a bit like FND. Or another analogy that Jeff said is, it's like a ball of wool. The wool might be okay, but it might be tangled and it might not be working while it's tangled. So even though the string is okay, while it's all tangled, it's not working. So in summary, FND is a dysfunction in the nervous system without structural damage to the nervous system. It results in a number of very significant and disabling motor, sensory, and/or cognitive neurological symptoms. For example, paralysis, abnormal movement. So people's arms can be, moving abnormally. They might be having these jerks. They can have problems with movement. So walking, not able to walk normally, not able to walk at all. Balance problems, tremors, severe weakness, severe fatigue, chronic pain, blackout. So people might appear to be fainting, they can have seizure episodes, and people can have sensory problems. And we have a number of people that actually go blind with FND. So just as disabling as if they had organic blindness from another condition. So FND represents an umbrella term. So some people might be diagnosed with functional seizures or functional limb weakness. So under FND, if you have functional seizures, if you have functional limb weakness or a functional tremor or abnormal movements or functional vision loss or functional swallowing disorders, this all relates to FND. So if you have one of these conditions, the person has FND. I know a number of people have got confused. They said, oh, I have, you know, functional left leg weakness. That means you have FND. This just describes the type of symptom that you have under the FND umbrella. And some people might have one of these symptoms and that might be all they have. Some people might have all of them, or they might develop additional symptoms over time, or the symptoms might change. So I know one person that started off with vision loss, vision improved, but then he lost his mobility. So the symptoms can fluctuate and change over time. So we did a study on people's experiences of FND around January 2019, and the report is publicly available through the Mental Health Commission through this link. But what we found was when we surveyed people with FND in Australia was how significant this condition was on people's lives, completely life-changing. And a lot of people were confused. They weren't given enough information. They were feeling unheard and voiceless. So for many people, they'd been given the diagnosis, but not been referred to services. Families, we also surveyed carers and families, exactly the same thing. They were confused, they were feeling unheard, they didn't have a voice in the system. We saw people slipping through system gaps in both accessing care, but also getting a diagnosis. People were ping-ponged between sort of neurology and mental health without actually getting any treatment. People sort of had a lack of trust of the health system, and they felt that they were being disbelieved, they felt that they were being judged, and they were facing a lot of stigma and discrimination, and that was within the health system, within schools, within the community, within the workplace. And associated with that is really because of a lack of awareness and a lack of knowledge about FND, both within the community and within the health system. And what we saw was major losses across all areas of life. So people, you know, losing jobs, losing employment, being excluded from schools, not being able to complete their education, losing their friends, losing all their life valued roles, you know, sporting activities, social activities, friendships. So really significant losses, and it became really obvious, like through the stories that we read, you know, the pain, you know, people were feeling this emotional pain and also the physical pain. So it has a major impact on the person and their family. So there are some symptoms with FND that are really visible. So, you know, when kids are going to school, this has been one of the symptoms that sort of come up, and we've had a number of schools be really, well, I've worked with children where the school system's been really anxious because the person experiences seizures. So seizures are one of these very visible symptoms. It can look like a person has epilepsy. So a person might have, you know, these hyperkinetic movements, so a lot of excessive movements, or the person might have these dissociative attacks that look a bit like an absent seizure. The seizures are really distressing. There is a risk of injury with seizures. People can fall and become injured. You know, people have it in a bath, you know, it can be highly dangerous. If people are choking on food, that's also highly dangerous. And people have broken bones. So we need to be aware of safety aspects. They're very serious, disabling. They're frightening for the person to experience, but they're also frightening for people to witness. So I know that has been an issue in schools. What is the impact on other children? What is the impact on the teacher? And trying to help schools understand how to support a person who's experiencing seizures is really important. So again, it might be that the person's shaking. They might just simply shake for a long time. They might have excessive movements. They might tremor. They might drop to the ground like a drop attack. So when the person's in the seizure, they're generally not able to respond to what's happening around them. So the teacher, the family might be talking to the person, and the person can hear everything that's being said, but generally they can't talk back. So they may not be able to speak, they may not be able to move, and that can last for a long time. It can also continue on post-seizure. So after the seizure, the person might not be able to walk and they may not be able to talk. For some people, it might be up to a couple of days. For some people, it might be 20 minutes or a couple of hours. So in order to support people going to school while they're having seizures, we developed a seizure management plan, and that can be provided to anyone that doesn't have it. But these were a couple of images from the seizure management plan. So it was identifying that what might trigger a seizure so that we can manage triggers. So if it's, you know, temperature, if it's a smell, if it's an emotion or a stress, what type of things might trigger a seizure, and what are the warning signs? So some people may have warning signs that a seizure might be coming on. So if a person is aware that, you know, things are starting to not be so great for them, can they get themselves to a safe place? So they might get, for some people might be an aura, they might start to feel dissociated or a bit distracted or a bit absent. And they may be able to tell that a seizure is coming on, so I need to get myself to a safe place where I'm not going to be injured, hurt if I fall. And also looking at the type of seizures that a person might have. So some people might have these hyperkinetic seizures. So they're the ones with excessive movements, or they might have hypokinetic, and that's when it might look like a faint. So they just collapse to the ground. And then other people might have these, you know, type of absent seizures where they're just not present, and it almost looks like they're in this trance-like state. So knowing how that seizure in the normal thing for that person presents and documenting, you know, how long might they last. So we generally find for people with functional seizures, the seizures last quite a long duration. So epileptic seizures, you know, might be less than 5 minutes, might be 3 minutes or 10 seconds. With functional seizures, they can go on for hours. Having an idea of how long the frequency, so how often they might occur, and then documenting, you know, what do I want people to do? So planning with the school, how am I going to need people to assist me if this happens? So what are we going to do? And also, what are we not going to do? So there might be things that make it worse. And then looking at what do I need after a seizure? So do I need to just lie down and rest and stay quiet, or can I get back up? And you don't need to call an ambulance for every seizure. So you might need to call an ambulance if the person is injured, if their seizure is different, or if they're not coming out of it in the way that they normally come out of it. So the other type of really visible symptom of FND is the movement disorders. So people who are paralyzed, people who can't walk, people who are in wheelchairs, people that have abnormal movements. So again, they can be quite visible. If people are having abnormal movements and their arms are, you know, hitting around, you've got to be aware that maybe kids around them, and being aware that that's an abnormal, unconscious, involuntary movement. People might be in wheelchairs, so we need to make accommodation as we would for anyone else in wheelchairs. We might need to adjust what they do in PE, etc., if they're having problems with weakness, limb weakness. Being aware that people can become paralyzed. So again, having a management plan in case that happens. And again, people might have problems with speaking and with swallowing. So being aware of that. But the invisible disabilities with FND that can cause just as much problems, people being in pain, chronic fatigue, sensory issues. Sensory issues are very, very common in FND. So people might lose their vision, but people might have sensory sensitivity. So they might be highly sensitive to sound, highly sensitive to noise, highly sensitive to bright lights. And then they might have, you know, comorbid anxiety and depression along with that as well. So these are additional disabilities that need to be accommodated within the school environment that may not be as obvious as the seizures and the motor problems. And again, also not there, but also the cognitive issues. So a number of people will have cognitive symptoms. They describe brain fog. They can't take things in. They might be slower to respond. So there's, and some people have memory issues as well, and really significant memory issues. People might wake up and not know their family, not know people who they've known for years. So people can get really significant cognitive issues. And one of the strategies that people need to do, and one of the things that we look at in OT, is really pacing. So people need to, it's important to structure in activities that are meaningful, things that allow them to do their normal life roles, but also trying to limit and sort of budget their energy throughout the day. So thinking about, you know, things that take up your energy, how much energy do they take up? You know, the spoon theory was like, you know, if I have start the day with the 10 spoons of energy, how much energy are things going to take up? And what ones do I need to do? What ones are important to me? What ones can someone else do or help me with? So part of, you know, symptom management in school is allow the person to take control, letting the person have a voice, learning to self-manage the condition, and making sure that the person, the family and the school understands the condition. Using graded goal setting, so helping the person engage in meaningful activities that are important to them, potentially dropping subjects that are not so meaningful to them so that they can, you know, budget their energy levels. Creating this occupational balance so people can have good days and bad days, so not overdoing it on a good day, because that can then lead to a relapse. But really important is to support engagement in life roles and meaningful activities, because without that people can really become quite isolated and depressed if they're not supported to engage in these normal life roles and meaningful activities. So in terms of inclusion in schools, schools do need to accommodate children with disabilities. Each state will have a disability strategy, and the Disability Discrimination Act makes it unlawful to discriminate against a person with any disability, which FND is a disability, and that includes all schools, kindergarten schools, public primary school, high schools, universities, TAFE, etc., private and public. So all children have a right to an education and a right to attend school. And the school is required to make adjustments to support that children attend school. So that might mean cutting back the number of hours, doing some work at home, some work at school, adjusting the subjects, etc. So reasonable adjustments is a legal requirement of the Act. And there is a notation unless it causes unjustifiable hardship on the education provider. So they have to be able to prove that it is unjustifiable, and that could mean, you know, the school can't afford to do something, if it would have a detriment on other people, or if it had a detriment on this provider, the other students, the teacher, etc. But there's always a way around things, and it's really about how people can work together to basically problem solve to support the child's involvement in the school environment. And of course, parents are really important in that process. So the parents or the carers are going to be the people who know that child best. And it's really important to involve the family in this approach in terms of partnerships, and also involving the child's treatment team. I've worked a lot with schools. I've had meetings with schools and various support people within the school in order to support children with FND attend school. And it's really important that everyone is collaborating together, and also, you know, adjusting, you know, based on the needs of the child. If the child's getting worse, if the child's getting better, it's got to be a fluid process. So all the time adjusting to the child's changing condition, and also allowing that child to attend rehabilitation is important, that the child is able to attend whatever medical appointments they need and do school and manage their condition. So I think, Pat, I've got your slides in now. So did you want to talk to your slides and let me know if they're not in the right order?
No, that's okay. I would just go back a slide to the DDA, so that I would just reiterate what you were saying, that that according to the DDA, students, the Department of Education in New South Wales anyway is committed to just any student who has a disability. Now, that can be a medical condition or it can be a learning disability. And in the case of FND, that incorporates FND, to be able to participate on the same basis as other students. So that's the language that the Act uses. Schools need to assess the students' learning needs. So they have every school has in New South Wales would have a learning and support team that's primary and secondary. So it's not a multidisciplinary team, but it does involve a decision maker like a deputy or the principal, and will involve the learning and support teacher. That's somebody in my role who liaises with families, students, and helps that collaborative process. And it also includes can include teachers as well as year advisors. I'm not sure in primary school if they have that structure of the year advisor, but in high school, they have staff who take on the role of looking after the welfare of students for a particular year group, which is very useful to have that extra, and that's somebody who can be utilised as a kind of a support contact as well. Kate, when you were meeting with schools, who did you actually meet with often?
Oh, it'd be often the principal, it'd be like a school nurse, a year advisor, the school teacher, school counsellor. So it varies. And then I had children in.
But as many people as possible, it would be better to include in the net.
Yeah, and Queensland's the same. Queensland the same. Often different schools have different matrices for how they develop their support, particularly in primary schools. But as you're right, there isn't usually a year level coordinator in the primary schools, but they often have a designated teacher or staff member who is looking after particular sections of the school community, and they often can be very helpful in assisting in plans and getting responses and making sure that things are updated.
And they actually use that language of collaboration all the way through the documents the department produces. So they're committed to actually consulting with families. I know it can feel like a real struggle that the onus is on you as a parent to start this process going. And often it is. And the parent that's a good advocate is a parent that usually has a better result than parents who are passive in this process. But the department needs to consult, has to consult, and should consult. So yeah, it's important to remember that. And as Kate said, adjustments may change over time. So that assessing of needs to be ongoing. So the relationship with the school has to be an ongoing relationship, I think. Now the school has to implement those adjustments on a day-to-day basis, and that includes exam supervision, exam provisions, which is what I was kind of interested in looking at in particular. And there are up to and including year 11, those decisions about what provisions and adjustments can be made in terms of exams are a school-based decision. But in relation to in New South Wales, we have a high school certificate exam, which is administered by the New South Wales Board of Studies. So that's a separate organisation, and there are separate protocols in relation to that exam. So I'll be looking at that that situation in particular. And that board, the Board of Studies, has now become the acronym NESA. So NESA approves adjustments for HSC exams, and they do it for the whole cohort, all of Year 12. So all the way through their principles is this idea that they are the adjustments need to be kind of not impinge on the consistency or the equity of how or the integrity of the examinations. And so they do not guarantee that they will provide the same level of adjustment that may have been granted at school level. So there's a whole separate process of applying for provisions when your son or daughter gets to that final stage of stage 6 of school. Can you go to the next slide? Thanks, Kate.
Was it that one?
Oh,
the HSC.
Here we go. Yeah, that'll do. Okay. Yep. All right. In terms of, oh, actually,
yeah,
is there another slide?
There's that one.
Yeah, let's do this one. Okay. All right. So in terms of that situation of doing the higher school certificate, and if you want more information, and I advise you to go to the specific document that that refers to all these matters. It's if you look up disability provisions, New South Wales education standards, it will take you to a web page for NESA, and on that web page is a link to the HSC provisions document, which is a guide they produce for parents and schools who will be applying for the any special provisions for the HSC. So in terms of reasonable adjustments that allow students to access the curriculum, there are the main categories of adjustment are seen as students having a learning disability, students having a medical disability, students having vision impairment, and hearing disability. So unfortunately, FND kind of can cut across all of those areas, as Kate was sort of explaining in her talk. And really the area that we're looking at in terms of if the student has FND is what they call the emergency provisions. In terms of the pre-existing categories like learning disability, that's somebody who may have maybe IM or maybe have a disability that prevents them from reading properly. So the department is happy to, a common adjustment might be to provide a reader and a writer. In terms of a medical disability, an example of an adjustment for that might be extra toilet breaks or rest breaks. In terms of vision disability, it might be producing large print exam papers. And in terms of a hearing disability, it might be an oral or sign interpreter that's provided to the student. Now, if you look at the emergency provisions, that's defined as students with unstable medical conditions. So in relation to something like autism, which would be kind of considered by the department as a stable condition, and there's lots of documentation to say that that condition won't change during the exam period. Why the emergency provisions are existing is that there are conditions like FND which are not necessarily stable, where a student may have an episode. They include chronic fatigue as an example, which drew my attention to these provisions. So these are provisions where the student is not the student may be affected in much closer to the exam and may change their ability to be able to sit the exam. In a condition like autism, you are encouraged to apply a long time before the exams, the year before, in anticipation of the fact that this condition is stable and won't change. But the emergency provisions can kind of include up to 6 weeks before the exam. when I spoke to the department, they said they would prefer it if the condition had been properly diagnosed and there was a treatment intervention in place, because that would allow the necessary kind of supporting medical evidence to accompany the application for these provisions. And you can apply for emergency provisions right the way up to term 3 in Year 12. And also, the exam, NESA also have to look after really late traumatic injuries as well. So if somebody breaks their arm 2 weeks before they have to do their HSC. And if a student has an episode during the examination, then it's covered by a different provision, which is the illness and misadventure provision, which means you have to apply if the student develops a migraine, for example, in the middle of an exam, the student would have to apply for either permission to resit or an estimation, and probably typically an estimation of their mark might be more appropriate. Right, can we just flip to the next slide, Kate? Which I think is one back, just to confuse you. All right, yes, okay. So in terms of the application, as Jeff stated, it can be quite an onerous process putting in an exam provisions kind of application. The NESA staff vet all those applications, and they say that they do have access to a panel of health experts, but they're not transparent about who that might be and when that panel might be able to sit. So it may not get the full consideration if it's requires a very quick turnaround. So obviously, the more time that can be put into the application process and allowing the NESA to make their decision, the better, typically. Any application has to be supported by medical evidence. So this means two kinds of medical evidence, really. There's the medical evidence that can be provided by medical practitioners. And when I was speaking to the department, they were quite happy to have medical evidence through a consulting GP. They said it can be difficult to get reports from treating specialists, especially if there's been a recent change of symptoms. So as long as the GP has a history of consistently supporting that child, and they're happy to look at that evidence. And also very important is the kind of having a history of school-based kind of adjustments. So making sure that adjustments are trialed in other exams before the HSC is very good evidence. And the school should be keeping good records of those adjustments. But again, it's something that needs to be followed up, I think. But the HSC, I've also put down there at the bottom, the HSC remains a handwritten examination. So yeah, they do not often provide computers for students. One thing this document that the department have written around HSC provisions lists a whole set of kind of provisions that are possible. And when I rang, they also mentioned, the lady who I talked to also mentioned the fact that they could possibly look at rescheduling exams if somebody is better in the afternoons than they are in the mornings, which I thought was very surprising. And that's not written in the HSC guide for provisions. But what is in the HSC proviso is also the student being able to access the exam at home or having a home supervision. So that may be something that you could apply for if there is major mobility issues. Provisions are determined on the basis also of a functional assessment. So, but what the department means by functional assessment, it's a little bit different from what Kate was talking about. The department means that they like to have a history of work samples, a history of the teacher being able to say, oh, this was a problem and this is how we adjusted for it. They're looking for evidence of what's happened at school. as well as kind of whatever medical evidence can say in terms of restrictions or limitations are. The disability provisions form, the application's open term 4 in year 11 before year 12, and they close term 1 when the student's in year 12. And this form is submitted by the school, so it has to be a collaborative effort with the school, and that's why building in extra time can also help in that regard as well. Look, supporting evidence includes medical diagnosis, and as I said before, the GP can be an integral part of that process. Functional assessment, which involves a lot of school-based stuff. Obviously, if you have a report from an OT, like something that Kate could provide, that would be very good evidence as well. But NESA weights that school-based evidence as being very, very important. And they also teacher comments are also part of that that assessment process. So having teachers on board and especially someone who understands that child's condition very well will be an important part of that collaborative process, or building that kind of support structure at school. The NESA also, they do have an appeals process. So if they don't grant the provisions that you request, there is an appeals process, and the NESA give themselves 21 days to consider that appeal. But with that appeals process, you can submit new evidence. So it gives you a chance to seek extra evidence if that is a problem. So I'm conscious of the time, so I'm going to hand over to Jeff. Thank you for allowing me to talk about that.
Thanks, Pat. Jeff.
Thanks, Pat. Yeah, thank you. Well, I'm going to speak from the point of view of having just taken a child through the high school process in Queensland, and there are a couple of major variations, but I will go through them when I hit them as part of the slides. But what I can say is that there's most certainly a very similar response of collaboration from the Queensland school perspective, and they too encourage a very collaborative response, but they do require the parent to instigate it, and that can be a very painful experience for some parents. I know, having spoken to other parents with other disabilities as part of their family experience, that they've struggled to be able to engage with schools based on trying to get the school to collaborate with them. Some schools are more likely to collaborate than others, and some teachers and some situations are easier to collaborate on than others. And some parents can't necessarily get to the schools to be able to collaborate. I know some work situations of some parents has prevented the level of involvement that they wanted, and then that produced some negative impacts for both the school and the child. So there are a lot of variables involved. But what I can speak to now is I'm going to hopefully speak to the experiences that worked for my daughter and some of the things that didn't work. And I most certainly am going to go through even other symptoms that Kate didn't mention that FND is part of. So please head to the next slide, and I'll start off. Now, I must admit, I was lucky enough that my daughter had a previous medical condition that did help us in our understanding of what we could and couldn't do in the school environment around asking for collaboration. So we did already have some understanding of certain disability requirements for the school around standards that they operate. We were lucky that our child came from a Lutheran school background in primary school through to the same Lutheran type environments. We did have some advantages there. And in that sense, we did also have, by the time we got to high school, some understanding of the support organisations that we were able to utilise. Having said that, though, a heart condition is most certainly very different to FND. My daughter's previous heart condition was SVT. It was where your heart rate can accelerate to above 400 beats a minute. And if that lasts for too long, well, basically she dies. So the response has to be quick and very hospital orientated, where with FND, the situation most certainly is very different. We found that, and after time, we most certainly spent some time with the school learning lessons around what does instigate times when you should call an ambulance and other times that you shouldn't. And that was very hard. So the school sometimes would cooperate with that and sometimes they wouldn't. That would often be very much a teacher-driven thing. If a teacher panicked, or dare I say it, had a reaction to FND that was a little bit scary, they would do things that weren't necessarily predictable. It's the same with the kids. Sometimes kids would do things that would be unpredictable around it, and that in itself became challenges that we had to look to work through with the school. And we've also had the situation where different parts of the school didn't believe that our child was sick, and that asked that the child not be at the school, again because they felt that the ability to care for her was not able to be continued. And so we had to have that discussion. But in saying that, she stayed at the school, and we were able to get her to a point where she was able to get through certain subjects. And a lot of it was through collaboration and through balancing the amounts of effort and fatigue, and dropping subjects and picking other subjects up, and also managing her day-to-day environment. And we did lose some. We most certainly didn't win every battle. There are certain things the school wasn't prepared to budge on, and other things they were most certainly happy to assist us with. Next slide, please. So in terms of some of the things that were reasonable and that we were able to do that worked well for us, was being able to engage with the teachers early on. We were lucky in the sense that her previous medical condition meant that there was already a lot of history in her medical records about how to deal with serious medical responses for her. So that was able to be something we could build on. But even if you didn't have that, we were most certainly able to use things like the seizure management plan. We created our own medical cheat sheet, and we used that as a form of communication in the initial stages every term. So because FND changes and the response to FND also needs to change, we would need to make sure these sheets were updated on a regular basis. And that was one of the tools we used to help both inform the head office, the different heads of different different subjects and different year levels, as well as then down even to the teacher. So some of the teachers asked us, look, can I have a specific response plan, please? And because we already had that for the school was able to generate, even modify it slightly depending on the teacher's situation. An example might be where, for example, what happens if that teacher's teaching on the top floor and the child has to navigate their way to that floor, and there isn't a close lift, and stairs are a problem for them at the moment. It could be any reason, could be a mobility issue, could be there's got sensory issues with their legs, could be a vision issue. All of those things can become part of how do I simply get into the classroom for that child at that point in time. And these are some of the things that we were able to get some good collaboration with. But there are other things that we weren't necessarily able to get good collaboration with. And some of them were, some teachers didn't believe her. They simply didn't think that what she had was real, and that also became a rumor around the school that what she was doing was faking, and that she wasn't actually sick. And she would spend time in the wheelchair for some weeks, and other weeks she'd be out of the wheelchair, depending on the different symptoms that happened to be prevalent at any given point in time. And that then produced some interesting trigger management for us. Sometimes it's known that the triggers for FND can be known. Sometimes they're not. We were able to find a few that were there, and that we were able to then manage. Some of the triggers for my daughter were things like hallucinations, things like stress and fatigue. And so those things we would often then map and manage to say if we knew that those things were coming on, we were then able to use strategies that might then remove some of the more acute FND symptoms. But some of the FND symptoms hung around the whole time, and some would come and go. So we had two sets of plans, one for those that were there all the time and ones that would come and go, and we'd almost always be introduced to new ones every few months. So so that in itself was a challenge as well. And we were also lucky that we had buddy systems set up for the child previously through her heart condition. But that in itself was a challenge because some of the children couldn't handle or didn't want to become buddies under the situation where they were then helping to look after her into those situations, where others were quite fine. We had some kids who were, yep, not as serious as her previous heart condition. I'm quite happy to help monitor her for this time. But again, these were things that the school most certainly wasn't comfortable with. They're going, nope, child shouldn't have any responsibility around another child's health. But sometimes the only person near that near our daughter was another child. And if Sarah fainted, or that's my name, my daughter, Sarah, if she fainted, then how would you then respond quickly if there was an incident where she had hit her head or she'd injured herself during a fall? Next slide, please. And that's one of those things where safety became a big ticket item for us, particularly around things like stairs. Stairs in the school that she was at were all cement. So that became a trigger point on its own, particularly while her mobility was compromised. Now, this slide here is something I did up because I wanted to show that some assistance was helpful, some was less than helpful, and others we had to search for and finally got good help, and others we didn't get good help for at all. So some of the things I'd like to talk to is what happens when you go from school to the hospital, for example. We were lucky that most schools will, particularly for the younger kids, have a teacher or nurse attend with the child to a hospital. And then it's a case of that person will usually stay until a caregiver can meet them at the hospital. What can happen though is that sometimes you need to be able to say to the hospital, I'm sorry, but that's not okay. What you're saying to me is that we're going to go home. You're not going to look at me. You're not going to treat my daughter or my son or myself. And at that point, you may have to introduce in Queensland, it's called Ryan's Rule. In New South Wales, it's called REACH. And in ACT, it's called CARE, where you can then question the response from the hospital to say, look, we think that there needs to be further examination of the symptoms or examination of the person, and that we feel that care needs to be changed from its current level. And I would encourage those that haven't heard of those three things to look them up for your particular state. Not all states have that rule, but it is most certainly something you may need in your grab bag of tools if you are at hospital, and particularly if a child's come straight from school and you're unaware of all their particular symptoms or situation at that time. We did have some success with pain management, and with other things we didn't. With pain management, again, particularly at school, it can be very difficult. One of our main symptoms for our daughter was lack of sensory input, both in her legs and her body, and sometimes in her arms and hands. So pain management would become difficult because she'd often feel the pain days and sometimes weeks later after a particular incident, because she could cut a leg and she wouldn't know that she'd cut a leg. She could bruise herself and not know that she was bruised. It even became a pet from one of her friends would walk up and say to her teacher, look, miss, she can't feel it, and go whack across the back of the legs. Needless to say, we had to stop that particular interaction, but the child didn't necessarily understand what that was causing. Even though my daughter couldn't feel it, it most certainly was something that was distressing her later. Some of the things we were able to do with GPs and specialists and physios was that sometimes we couldn't get someone with FND experience to help us. And so we were able to get a particular hand physio up here in Brisbane to help my daughter out, particularly around going from not being able to use her hands to using a computer to then writing. And that, of course, was something we had to bring the school along for as well. We had to say to the school, look, she can't write at the moment. Can she please utilize a computer? And of course, as Pat rightly pointed out, you can't do that in the HSC. You can't really use a computer. So there has to be ways that and tools you can use to help around writing. And the Queensland version of ATAR does have some of those, and they including breaks, which allow the child to stand up and walk around, or even go to the toilet, as Pat pointed out. And we utilised those quite extensively, particularly in long exams where a lot of writing was required. So that way she wouldn't have to write for large blocks of time. They'd only be, say, half an hour. She'd be able to stand up and then instigate again for another half an hour. We also had quite success with a brain injury clinic. Even though they didn't have any idea what FND was, they most certainly were able to assist us with some of the mobility issues and treat some of the nerve responses that were happening with our child. And they were happy to learn along with us. The difficulty with that, of course, is that they too didn't know all of the ins and outs of FND, so they too were learning. And so there were some things that they didn't necessarily get right all the time. And we weren't able to use all of their information in some of our dealings with the school. We had a good GP. We were very blessed in that sense, and that certainly was a good contact point for the school. And the reason I would say a good GP is someone who can liaise with the school around referrals and around information that the school might want that you can't provide for them. And we can't all be experts. And I most certainly am not one. And I most certainly needed the GP to assist, particularly in terms of how to get forms filled in, and particularly around the last year 12, where there are 3, particularly in the Queensland, there are forms that they require a specialist or GP to fill out. So if you've got a good relationship with a GP, it becomes easier to get those forms through the system.
Yeah, I would just back Jeff up on that. And I think even at the start, in your very first kind of interactions with the school, if the school will be looking for a GP to trigger the whole medical planning process. So make that part of that first response is something from the GP on paper.
And absolutely. I mean, the other thing that, again, this one's very difficult. We were lucky enough to have enough money at the time, and it did cost a small fortune. And that was that we did keep a pediatrician with our daughter for an extended period, all the way up until she was about 17 and a half. And that made things a lot easier because he was able to then coordinate some of the things we needed with specialists, neurologists, and counselling that we weren't able to access ourselves. And that was something that we were very lucky to find a pediatrician who had some experience in FND. And I would encourage, if you have the time and the money, to go looking for one if you can find them. They're a great support, and they're a great supplementary mechanism that can help the GP as well to get access to things that you might not otherwise be able to access. But again, they weren't as effective the older our child got, mainly because access to things as an adult and as she aged out became more and more difficult. Because as waiting lists, and we're still on one particular waiting list that we've been on for a year and a half, we started it with the pediatrician almost 18 months ago, and we're only now seeing the fruitions of being able to see that particular person for an appointment in the coming weeks. He wasn't able to assist us more than that. No matter how much we paid, no matter how much we begged and pleaded, that was the best we could get. So in that way, even though I know it's a long time in waiting, I still would encourage getting on those waiting lists and just keep pushing. And it is hard. It took a lot of grey. I don't have any grey hair, but I'm sure I've got some sprouting out somewhere from the amount of time it's taken me to try and get appointments. Our neurological experience was quite bad, and I know I've heard some great things about some great neurologists. I've met a couple in my time with Kath helping me navigate the FND environment. But the personal interactions I've had with neurologists for my daughter, who she's been referred to, have all been bad. They've literally all been, yep, do a couple of tests. Yeah, she's got FND, and then they basically put her out the door. And that's happened to us twice. And I was very disappointed each time. And we'd end up back at the pediatrician saying, can you get us somebody who can at least help us in this space? At least we got a diagnosis, and that was the diagnosis we used, because some of the school, particularly the ATAR system, required a neurological assessment to say that she had FND. And I'm not sure if that's the same in New South Wales or other states, but in Queensland, there was part of the form that said, do you actually have a neurological assessment done for this neurological condition? So we were lucky enough to be able to get one, but it took a long period of time to get it.
I don't think a GP in New South Wales can make a diagnosis like that, and I don't think they'd feel confident doing that. So yeah, you are locked into getting a neurologist for that aspect of it.
Yeah, and again, it depends. I don't know the other states. I only know of Queensland, and we were lucky enough that we did manage to get that. And I do believe each state has as Pat pointed out, New South Wales most certainly has variations in the way that they deal with their Year 12 exams and the way that they deal with it. And most of them, from my reading, they do allow the school to do the alterations and the changes up to Year 11. And it's only when you hit Year 12, even though they're still doing some of their work in Year 11 for their final scores, they still allow the school to do most of the, if not all of the modifications and the changes and the little changes and moves that the child might require. We did have some great OT assistants, but we only needed them from time to time, and most of it was around functional response to having lost a particular part of movement or skill, to then try and bring that back. And one of those OT situations was in a hospital. My daughter was lucky enough to get a week in one of the hospital situations to get FND treatment. And there was a great OT in there that helped her out to gain access back to her legs. And she gave us some great techniques that when our daughter lost her legs, access to her legs in subsequent occasions, we reused those techniques to try and get her back. And I believe it then took less time. But as you can hear by my comments, it's a village approach. If you can get the best care you can get in each of these areas that I've got on the screen, I'm hoping you will then find the best pathways forward to manage FND and manage symptoms and responses. Next slide, please. And again, there may be other areas you may need to cover as well. We most certainly didn't investigate some areas of the medical fraternity that most certainly could have helped us. I know most certainly we didn't access massage in areas that we possibly could have. For example, my daughter had some issues with touch, for example, because she lost sensory feeling in most of her body. She doesn't like hugs, for example. And so it was very difficult for her to engage with her friends, and she became very socially isolated at times when she felt she couldn't handle people touching her body for any reason. It includes medical. So it was a very troubling time for her at times. So some of the things that I was talking about in terms of tools that you can utilize with the schools. Again, some of those things are when you're sitting there at the first instance, or when you are trying to renegotiate with the school, think about it from the school's point of view as well as yours, and include how a teacher might respond to the FND symptom. If you do that, we've had a lot of success working from certain points of view and actually sitting there and running through, okay, what would a teacher do with the child if he or she is in the classroom, and then what, and then this. And so running through those scenarios did help us with then developing plans for the school. So the school went, yeah, we know what's happening. We know that if this symptom does rear itself, we know what we need to do. And we know, okay, we don't ring the ambulance in this scenario. We ring you first, or we just have a go to the nurse's station, keep her in a quiet, enclosed, dark area. Again, photosensitivity can become a real issue. And sometimes the kids don't know that they've got these symptoms. Sometimes it's the observation that can become your knowledge about the symptoms that this person has. And that can be a real challenge, particularly if it's a child who sees it or another child who sees the symptom. And you then have to okay, say to yourself, all right, was that real? Was that something that the child thought they saw? Or was it something that they actually did see, and we can then process, and hey, that's now something we add to our level of response. It's not that you don't believe them, it's just it can be very hard navigating the, okay, what kind of symptom was the child actually putting out? I'll give you an example. My child was sitting on the floor reading a book and she passed out, she collapsed. It was an FND drop seizure. And there was no lead up. But then the next day she had lead up, as in she knew it was going to happen. So she let some of the people know around it, because the teacher wasn't in the room. So they managed to be able to get her to the ground so she wasn't then going to fall. And they managed then to get the nurse able to get to the room and be able to get her onto a wheelchair and get her to care a lot quicker. And what happened for our child was, we didn't know at the time, but she would get these symptoms in bunches, in clumps, and that she would have them over a few days, and then they would disappear again, and then they would reappear again. Sometimes it triggers, sometimes not. And so these are some of the things we learnt as we went, that and by making sure we documented these things and making sure they were included in the school's plans, it then became an easier response for then future activity. It also meant that we had the evidence, as Patrick was saying, you had then evidence of what is needed then for future changes. So if you're then going to somewhere like ATAR or the New South Wales version, you've then got all this evidence. You then don't have to go scrambling for them. You can say, here, mountain of evidence. So Pat, you want to say something?
Oh, look, I was just saying that that can be a bit of a nightmare, the day-to-day schooling, because you've got different teachers sometimes coming in to cover classes who won't be aware of the situation this in the same way that a teacher, a kind of regular classroom teacher might be. So this is where the plans become so important, and making sure that you supervise what goes into that plan, and regularly updating that plan, and making sure that you prompt that all teachers need to be across that plan, not just your one classroom teacher.
And the school did some great things for us, and this is something they hadn't done in the past, but they've now included. Is they actually developed a card system, and so that children like my daughter were able to carry these cards. So all she had to do was flick it in the air, and all the full-time teachers knew that if she put the card in the air, that was a symptom of there was either going to be an episode, or she needed to leave the room immediately to make it to the school medical facility, and that the person would need to go with her.
Yeah,
and,
so she didn't have to negotiate with the staff
nope,
member. She
didn't have to negotiate.
Yeah,
that took a year.
Wow.
That took a year, but it was a great lessons learned after a year of building up our response plans. That was one of the things that the school came back to us with, and I went, "That's just fantastic," because that lessened my daughter's anxiety from probably about an 8 or a 9 going to school each day to about a 4.
Yeah.
It made that bigger difference to her, and that's why I suppose from my learnt experience, the tools become very important. Not just as a safety blanket for the teachers and the school, but also as they can then themselves look at developing other tools that can assist. And I said, we didn't come up with the school did, and we thought that was a great mechanism, because it was that negotiation was often the hardest part, and that was actually, it turned out to be one of her triggers. Was the actual instigation of these discussions was a trigger for her. And we had one teacher, I won't name him, or it was a him, but he was a trigger for her. Every time she would have to negotiate with him, she would trigger an episode within 24 hours.
Yeah. Wow.
Like I have one situation where this happened. She had a conversation with him within 24 hours. She had delayed concussion and collapsed. And we then had post-traumatic concussion syndrome, because she knocked her head multiple times over those 24 hours. But each time she'd get up, she wouldn't remember that she'd passed out. But we didn't know that at the time, of course, that this teacher and the negotiations with this teacher was a trigger. We found out afterwards, and we were able to do something about that. And we said to the teacher, look, it's not you. It's the fact that the child can't handle the negotiation process with you. It's not that she couldn't handle it with everybody. She just couldn't handle it for whatever reason with this particular teacher. And that's one of the challenges. It might not be the school that's the trigger. I know I've read of situations where school is the trigger for a child not wanting to go to school because of FND. Sometimes it's something at school. Sometimes it's something they're doing in school that can be a trigger, or it can be all of them. And that's one of the real challenges and sadness that I see in the condition. And for my daughter was that I'd often cry over this, was sometimes it was just impossible to know what was the cause and what was the trigger for what would otherwise be a normal day for the child. And a normal day, though, for my child was having multiple ongoing symptoms. But I've got a slide that'll describe her day-to-day in a moment. Next slide, please. And I'd have to say, I'll reiterate, the building a relationship with the school is probably your biggest tool that you can use going forward, particularly as the child gets further and further along in their education. The better your relationship with the school, the easier it'll be then to build these later tools, particularly when they get to the end and the stress levels start to increase, particularly around the HSCs and I can't repeat that enough, because that's one of the things that we had to leverage. Particularly when it was touch and go there, where she was having so many head knocks and memory loss that she couldn't even remember who she was the next day, and yet she was supposed to turn up to school and do revision on stuff she couldn't even remember she'd done, and that panicked her on several days. And that feeling of isolation, and particularly in terms of memory loss, and particularly if you get repeat symptoms that cause injuries, that can be incredibly disheartening for a child and for parents as well, and for those around them. Some of the things that would happen, one of the things we learnt early on, that my daughter was hiding in toilets. She would often go say, I need to go to the toilet. That's the best she could negotiate. She'd go to the toilet and then have an episode. And that episode would produce a head knock. So she'd have concussion. So then we'd have to call the ambulance. Then the ambulance would have to go to the hospital and then get checked for concussion, which she would have. And then she'd have to take several days off. And then she'd have all the other issues. Concussion would come along with it. Things like photosensitivity, which of course then became almost a constant. My daughter now has days where she can't handle bright lights for sometimes long periods of time. She also has had issues where her vision would part. This is one of the challenges. You can probably see me disappear and then reappear. That would happen to her vision. And that's one of the not so common, but is most certainly part of the FND experience for some people, where their vision partially becomes unavailable to them, and then it can come back, and then it can be lost again. Anything from stairs can be an enemy. Pathways can become an enemy, particularly with mobility. Wheelchairs, particularly those that aren't necessarily used to wheelchairs, if they're in a wheelchair all of a sudden, can be a really traumatic experience. My daughter hated the wheelchair. She didn't tell me until later, of course, because she didn't want me to feel bad about it, but she hated every single wheelchair she was in. But it was because it was the anxiety that got to that point to have to put her in the chair. And so there was a lot of times that we had to spend times building up her dignity because she felt that she'd lost some of her dignity in some of the symptoms. And we did rely on some of her buddies and some of her friends to be able to have positive responses to her. And it was not just to the teacher to say, yeah, do this and don't do this. We also said that to some of her best friends who spent a lot of time around her. And we had to say to particularly to the kids, progress, not perfection. We don't expect you to be perfect. We don't expect you to have the correct response all the time, just as long as we can find out what the symptoms are and push it back into our learning, push it back into the information, and we build up a body of knowledge. And so that became some of the things that we spent our time doing, was building up that working relationship with her friends, with the teachers, with the school nurses, with the different learning coordinators, particularly around different subjects, to say, okay, what can they do, what can't they do, and it builds into a bigger picture. Next slide, please. And that goes back to Kate's points around building that resilience and building that grit and changing the priorities, because it might not be, instead of getting a good mark, it may be just getting a mark and getting through it. And I can speak to some of my daughter's symptoms, and she would suffer from blackouts, paralysis. She'd lose movement, sometimes in one side, sometimes in both, and sometimes from the chest down, sometimes from the neck down. And she'd lose feelings. And one of the symptoms she still has, she still can't feel from her chest level down to her toes. She has no sensory input from those parts of her body. So you can imagine what kind of day-to-day challenges that produces. Everything from going to the bathroom to, dare I say it, kicking her toe, to having a scratch on her leg. My daughter is she used to be a great dancer. She was dancing from age 4 all the way through to age 14, 15 when she was diagnosed with FND. She only just started back the last few weeks back into dancing again, which she felt comfortable enough, even though she still has no feeling. She feels confident enough that she can see her body. She can then respond and do some of those things in a limited way. She doesn't take in full activities, but she does feel she can take part partially. She loses sometimes feelings in her arms and use of her hands and arms. And we've been lucky that we got access to a hand OT/physio who did some great work up here in Brisbane. I think I've added them, Kate, to the list of FND people, but they're not FND specialists. They were just specialists in recovery of people who had lost use of their arms and hands. I must admit, I used their techniques on multiple occasions in future episodes. Some of the worst ones she had were hallucinations. She would hallucinate sometimes for long periods of time, and that would cause her great distress. And it was fine when the hallucination was just someone walking past, but when that person then did something, and they were doing some really nasty stuff, I won't go into what they were, but that would cause her great distress and great anxiety. And that's when the card situation would prove to be very helpful, because then she didn't have to explain what was happening. She just was able to get herself to medical help and then be able to process from there. And of course, with multiple fainting episodes, and these would happen over 2 or 3 days, she would end up with what's called post-concussion syndrome, where she would have consistent concussion symptoms over long periods of time. And that can be greatly disheartening for people. I know I've talked to other medical people who've seen others with this condition, and it can be really disheartening when you can't deal with bright lights, you can't deal with sharp noises, you have hearing issues that aren't even related to FND, because you're now ending up with situations that are concussion related, not just FND related. So you end up with a situation where sometimes her concussion symptoms would be prevalent and would be the things that were showing, and sometimes her FND symptoms would be showing, and sometimes they'd mask each other. And that would be greatly traumatic for her. But again, these are things we learned. And as we were able to control some of the concussion syndrome symptoms, we were then able to learn more about the FND symptoms it was hiding. And these are some of the things that that can be hidden with FND. And it's one of its cruelest parts is that it can hide things like hearing loss, nerve issues. My daughter's previous heart condition was a nerve issue, so she got tested for within an inch of her life when she was 15, that they initially thought her FND could be a nerve condition, and it proved that it wasn't, but she most certainly was tested for it, and she's broken bones in her hands, she's burnt herself, she's cut herself, she's had infections, and she can't feel them, which has proven to be quite dangerous at times, particularly when she broke a bone in her hand a couple of months before the end of year 12. That was not exactly fun. But there were ways to manage that, and it was in some ways a blessing. She couldn't feel the pain most of the time. And some of the things that do happen, of course, is with anxiety comes personality change, and some of it can be very disheartening for the individual and can be disheartening for those around them. She most certainly burnt out some of her friendships, and that was very sad because some of those friends had been with her since the time of her heart condition, and that was very sad. But she also was able to make new friends. But that in itself was a big challenge for her. And I'm happy to take questions if you want to ask me about any of the things we did for any of those particular symptoms. I'm happy to share what worked, and I can also share what didn't work, because there were some things we did that didn't work for her, particularly in terms of movement and memory loss and hallucinations. But I most certainly did have some great successes with getting movement back for her. Next slide, please. Okay, as the next slide comes up, one of the things we learnt in the senior year, so it's a combination of all the things that we learnt, is that exam times aren't finite. You most certainly can, as Patrick mentioned, you can get them changed. The only thing you've got to watch for, and something we didn't learn until almost right at the very end, if you end up missing multiple exams, most of the time they only have one date to resit, and that itself can be a problem. So you've got multiple exams that have been missed, you often end up with having to sit that multiple exams on the same day, which can often add further anxiety rather than minimizing it from not having sat it on the day that it was originally specified. So the challenge can be, and we did this, we would often let Sarah sleep right up until a few minutes before she had to leave to go to school, to try and give her as maximum amount of rest that she could over that time period. And part of that was also because she was having memory loss, and we wanted to try and give her as the best chance each day to be at her best in each exam. And special conditions, in my personal opinion, if they're available, make use of them. Even if the child doesn't have to on the day, make sure they're all in play, and yes. Because definitely, it's better to have them.
Good advice. Yes, get the whole gamut. Yeah. Just in case, you know.
Yeah, she didn't need the bathroom breaks, but hey, that's great. But she most certainly needed the stand-up breaks. She needed to get up, move around. She needed to flex her fingers because her writing would deteriorate. And this would happen even when she was in writing assignments. This is why we were able to move it to a computer. She would become illegible after about an hour and a half. It literally would be a straight line. It wouldn't be letters. It would literally just be a straight line, and she wouldn't be able to then progress back for several hours, or if not the next day, to be able to write again. and it can be very difficult. Again, when it comes to wheelchairs, I know my daughter hated them, but we were able to get some successful changes for the school to help us with how to access rooms that weren't necessarily set up for wheelchairs, and allowing for, again, computers, desks that can be modified, leaving chairs out of desks so someone who needs a wheelchair or someone has a motorized chair can get in behind them easily. Some of those things are really easy to do, but they need to be pre-planned. And changing school room locations so that the child doesn't have to climb stairs. Again, takes a lot of planning, but not impossible. And sometimes even just having the right chair can make a big difference to a child's anxiety level when they're trying to do something. And sometimes even the best intentions, are you okay, sometimes can become a hiding opportunity rather than a chance for them to be able to trust and be able to get help. So it can be a challenge, particularly at the end of exams when people are generally heightened with anxiety anyway, to not feel isolated and segregated because they need special dispensation. So one of the things we did was try and explain regularly, because the child had memory issues, Sarah, that if someone asks you, are you okay? Give an open and honest answer. Doesn't matter how you're feeling, just give them the answer. That way you've at least got someone else then can judge and apprise of how you might actually be okay or not okay. Because if you don't, if you say you're okay and you're not, and that could then develop into something else. So my final piece on exams would be just make sure you've got as many of the, that's my daughter, my youngest, who wants a cuddle. Make sure you've got all the dispensation and the conditions set that you can get set for the exams, and do try and lay out for the child who's trying to do the exams the best conditions that you can for those environments. Next slide, please. And some of the things that are in schools that aren't necessarily to do with the education itself, and that is that there are lots of social challenges for my daughter. And it became from someone who was in large dance troupes to being in large activities, to then having to scale a lot of that back. Some of the social challenges were that she wasn't then able to operate in large environments. One of the jokes when COVID hit was, well, guess what? Now everyone gets to experience what I've been experiencing, that I have to isolate myself and I have to sometimes do things that I don't necessarily want to do, particularly in environments and dancing, of course, where people have to interact and touch all the time, became very difficult for her very quickly. And loneliness became and bullying became part of what she had to deal with. And we did have some good successes with the school framing some of the bullying responses, because bullying due to disability can be very different, particularly for invisible disabilities, can be very different to normal bullying, because often it can, the kids know that what they're doing is wrong and that they shouldn't be targeting this person, but they still do. And part of that can be sometimes that they feel that the person who's being treated specially doesn't deserve special treatment. And so we needed to spend time negotiating with the school to say, hey, if that bullying is starting to appear, you need to nip it in the bud pretty quickly. And you need to be with those students to say to them, hey, yes, we can't share the medical condition with you, but the child has a medical condition that changes. You know, it's not just something that's the same every day. And that in itself can be a big learning curve for peers, that medical conditions sometimes are not going to be the same every day, that just because you've got, you know, it's the old adage, if you're missing an arm, you're missing the arm today, you're missing the arm tomorrow. With FND, you could be missing your arm one day and it could be back the next. And that kind of interaction can be very difficult for peers. And they can become very judgmental, become very difficult even to engage what would be considered to be the people's friends around them. But again, we spent a lot of time with them to try and ensure that they had an understanding of the condition and understanding that it changed. Social media became very helpful. I must admit we didn't have a lot of negative social media experiences. Most of it was very positive because she was able to then connect with other FND sufferers and other children like herself, because then she didn't feel like she was the only one. Because at school she was the only one who had about 1,000 kids, and she was the only one who had the condition in her grade, and she didn't know of anyone else who even had it until we were able to start connecting with people like Kate and social media. And that did decrease her isolation, but even towards the end, she still felt very isolated, because even her exams often had to take place without other students in the same locations, and that became very difficult for her at times because she felt isolated then from the other groups. So it then became important for the school to make sure that they reintegrated her for activities, even particularly around exam time. Next slide, please. And at the end, when we were getting closer to the end, and we managed to get her to sit exams, and she still had lots of memory loss, and she was forgetting sometimes each day what she'd studied the day before. We did end up talking about what we needed to do to get her to different places, what we might have to do after school had finished. Would she get to university? Would she have to do a TAFE or a bridging course? Would she have to look at a trade or an apprenticeship? And what assistance would she need, particularly in terms of employment agencies? And one of the great things are these things are available, that even if they do miss and they don't hit the mark when it comes to year 12 and they have to pull out, or they don't make the end and don't reach that level, there are bridging courses. Yes, they will take extra time, an extra years per se, if they're then wanting to go on to university, but they are available. And there are some special dispensations for, particularly in TAFE and apprenticeships, where you can get some special things done. Admittedly, in trades and apprenticeships, not as many as in TAFE and university and the employment agencies, but they are there.
Jeff, can I just jump in there? Also, when you're sitting your HSC, you can do it over a number of years. So I think you have 3 or 4 years to complete your HSC. I mean, it is like water torture to to have to draw out that year, but it's possible that you can do it.
Yeah, and that is one of the tools absolutely that you can use, which is extend the length of time that you're at school. And if a child's got friends in younger grades or siblings in younger grades, then that most certainly is a tool that I'd say would be at the top of the list. But if a child is feeling anxiety and particularly isolation and doesn't feel like they would gel very well with years coming after them, then it might be a little bit harder to sell that idea of extending their time in year 12. And we had that conversation. It was a very difficult one of, look, can we extend it over 2 or 3 years? Now, we were paying for private school fees, so I certainly wasn't up to wanting to spend a lot more money on school fees. And she most certainly didn't want to have to go to another school to finish her year 12. So those are some of the things that can appear in the conversation. But again, the length of time of year 12, I think, is a good one. I think it should be one of the first things in the conversation. But do be aware, if that conversation does end up in a stalemate, there are other pathways that you can take where you can still get to either a job or to TAFE or to university that doesn't necessarily require extra time in school, if school is part of the trigger and part of the triggers and part of some of the challenges. And that can be one of the challenges around transition. Next slide, please. And that can be one of the harshest parts of this condition. Is transitions often can be one of the biggest challenges. But if you can get the transitions to happen, then often those transitions can be quite powerful in assisting the sufferer and the parents and the school to be able to get through get further along the pathway. Kate, do you mind taking us through the resources? And any questions, please don't hesitate to ask or put them in the chat.
Yep. So this is our website, which has got a number of resources on it, fndoz.org.au. Neurosymptoms.org is a website put together by neurologist Dr. John Stone in the UK, and there's lots of information around different FND symptoms on that. We have a YouTube channel with a number of educational type videos on that, and that's the link to the first YouTube. The recording of this video will also go up there, and then we've got a couple of other videos which are an introduction to FND by John Stone. There is an app for FND which allows people to monitor symptoms. It is a UK app and it is tailored a bit more to the UK, but that is available. And Jeff, the last one you put in there, what was that one? The review one.
Yeah, that's a review of the app itself.
Oh,
so
okay.
if you want to utilize the app, go there first and see what this particular health website in the UK takes us through its paces. My only comment is it is very UK based, so a lot of the resources point you to UK based information and resources. But in saying that, it does have some great tools that can assist, particularly in terms of monitoring and building up a body of knowledge.
Yep. Cool. Jeff, did you want to talk about this one?
Sorry,
Did you want to talk to this one?
Yes, please. Yes. And one of the things that I'd like to end my section on is that often it was getting to the start line was the victory, not necessarily trying to get a good mark or trying to get to the end of a subject, but getting sometimes to the start line was often the goal, and then seeing how things went. Because it was often very difficult just to get Sarah to the start line, which was just getting her out of bed, getting her to the point of view where she wasn't too anxious about going to school. And so the victory was getting her to the start line at the start of the day, and that in itself was a victory. And it was a most challenging time, and one of the things that I know we're trying to do is trying to get as good resources as we can and trying to get creative solutions to what is essentially a very set of complex problems.
Great, thank you. I'll stop the share. Does anyone have any questions? You can type a question in the chat because we can now see the chat now that I've stopped the share, or you can ask questions.
Yeah, can I ask something?
Yep, Kathy, yep.
Year 10, now she hasn't been at school since March. Our pediatrician basically said no school till May. Trying to do home learning now. With her FND episodes, she wasn't lasting till 10, 11 o'clock at school. She was having drop seizures. She could last 6, 7 hours where we've had an ambulance management plan to bring her home. How do we get her back to school and basically some normal activity? Everyday episodes.
Are her episodes ongoing?
Yeah.
Yeah. So you definitely need a management plan in that case if the episodes are ongoing. You'd need a lot of support working with the school around what do we do in these circumstances, a bit like what Jeff has explained. But also it'd be a gradual return to school. I mean, I've got clients that are only going to school, 2 hours a week and doing the rest from home, and then sort of gradually trying to increase that, because obviously the social aspect of school as well as the education is really important, especially for the child's development. And it's working in that sort of pacing, what her symptoms are, how much education she's able to do, what's important, what's not important, what can she drop, and also as Jeff was talking about, what aspects of school might be a trigger. Exams can be stressful for anyone. So what, you need,
We've had meetings with Queensland, with Education of Queensland, head of learning department, head of special nurse department, head of another department, and they said because of the new stuff with the COVID, how about we try some home learning? But we'll also notice she's starting to enter social like all away from peers.
Yeah. And that thing, yeah.
Can I make do you mind if I make a couple of suggestions? We had, particularly around when we were suffering from, when my daughter was suffering from those blocks of seizures, one of the things we did attempt to do on the recommendation of one of her specialists was to attend school at different times for short periods. So not just from the start and see how long she'll go for, but attempt to go at different times of the day to see if she might last from, say, 10, 11 o'clock through to the end, or maybe 10, 11 o'clock to say 1, because it could be that the social interaction may help or it might hinder. And that was one of the things we did to assist her to socially reintegrate back into her grade. And we did end up with some success with that, because there were some days that she simply couldn't get up in the morning. She simply couldn't make that first set of markers, which was get up and get to school in a normal time frame. But yet getting her there later, and I know it was incredibly hard disposition. I actually lost my job at one point based on this, because my workplace wouldn't allow me to have that kind of flexibility. But because I was able to do that, it did mean that she was able to find a middle ground. Now, it might not work for you, but that was one of the techniques that we did use that was reasonably successful, but it did take some time.
Yeah, that's what we're finding. We don't know any of her triggers and stuff like that, so it makes it hard. We know she's got very quickly.
Yeah, it's incredibly hard when you don't know the triggers, and you might not get to know them. But and again, at the time we didn't know them, but there were certain times of the day where she was better, and other times of the day that she wasn't. And it might be, I'm not sure if your situation may be similar, but that would be my next step, would be to say, can we negotiate for different times? And it might be that things at different times of the day she may respond better to.
We've tried that for the last year and a half. Right now, 10 o'clock, she's gone down. Can you come up to the school and help us deal with it? In the special needs area, because she's got ADHD and autism as well, on top of everything else. So, and anything after a certain time, she's just, I'm ready for bed now.
Yeah,
it's a hard one.
Yeah. Does the school have an area where she can sleep?
Not really, because we've tried that when we got to the point, and it got to the short time. School's nearly over. We can't stay. We can't supervise. Or we've got nowhere else really. We haven't got the staff to do supervise. We can't move her. We can't do this. Being in special needs area with her tonic seizures, it puts stress on the other kids with their special needs and stuff as well.
Yeah, it's a hard one.
Yeah, that is a tough one.
Yeah. And we do find at home it's kind of a safe spot. She doesn't have as many, but as soon as we take her out, even the public or the community, the shopping centres, she's always having.
Yeah, we had to utilise the non-sensory times in shopping centres and in shops. I know Coles and Woolies do a decreased sensory shopping experience at certain times of the week.
Yeah.
That might assist, but again, it's very difficult. Obviously, it's the social aspect of shopping centres. They don't do it, but I know some of the large stores do. And that was successful for us for some periods. Wasn't all the time, but it was successful for some.
I know I did. I did put a post up. I think might have been on her with her Facebook page, with the younger group, ask about social groups and stuff with her. But yeah, it's been a hard roller coaster.
Yeah, it is for a lot of people. Okay. Were there any other questions? And if you think of a question later, you can always email us. My email's available in the group, and it's you can email in through the website as well. And you've all got my email because I emailed you the link. So if there are no other questions, we might end it, but the presentation slides will be available and the recording will also be available. So no one's going to jump in with a question?
Thanks,
no. Okay, we'll end it there, and thanks everyone for attending.
Thank you, everybody.
Thanks. Bye. Bye.